So first up, I am going to hand over to my colleague, Andrea Pavlikova. Andrea.
Thank you very much, Nessa, and good morning, everyone. Welcome to this webinar, which is jointly organized by Shiroko Exchange EU-funded project, which looks at capacity building for integrated care and European Connected Health Alliance. And as Nessa said, we are organizing this session in the context of digital care, digital health care and housing event in Scotland. So today, the purpose or the objective of this webinar is to share the experience and exchange the knowledge on the communication and training strategies in two particular regions and countries. So we have the case study of Scotland and Lithuania. But before we kind of like drill into this local experience and concrete examples, we will also hear at the beginning from Andy Bleeden about the newly established thematic innovation ecosystem on integrated care as part of the European Connected Health Alliance. So without further ado, we will actually kick off with Andy, and then we will follow by 3 presentations from our colleagues from Scotland and Lithuania. And as Nessa said, we will then have a dedicated time for discussion. So over to you, Andy.
Thank you very much, Andrea, and welcome all who are joining still now, I see. One of the nice things about this is I can already spot some old friends and old relations, I should say, from across the globe, from the rest of our ecosystem network. So welcome colleagues from Australia and Greece and various other countries. Just to echo what's been said so far, today sees the launch of the first of our thematic innovation ecosystems and this one is on integrated care. I want to just talk a little bit about the background to this and the why and the wherefore, and then I want to get on with the rest of the program here from decent examples of good practice, both from Scotland and Lithuania, and also from the rest of you, from some of the ideas about where we could take this in the future. The European Connected Health Alliance, just so you understand, we're a member organisation, a global member organisation, and we connect up the dots between all our members using our ecosystems. So our ecosystems are there, and I'll come on to those in a moment. But the idea is that we're bringing together all of our member organisations, 95% of which are public not-for-profits, together to collaborate and transform health and social care. People become a member of us for the following reasons, but I'm not here to talk about membership today. I'm here to talk about ecosystems. Ecosystems we see are permanent multi-stakeholder gatherings, bringing together all those stakeholders you can see on the screen in front of you. They're there primarily to break down silos, transform healthcare and social care delivery, and also create economic growth. The difference between what we see as ecosystems and maybe workshops or seminars is these are permanent, and we also feel that they're strongly led where they're led with the need, and that's why we have patients and citizens at the centre. That's vital, but all stakeholders are involved, which is why we're pleased to see such a different group of stakeholders here today. Our ecosystem network's growing at a rate I barely can keep up with, and this changes just about every month. In the last 2 years, our network of ecosystems doubled, primarily because, or maybe even despite of COVID. That's meant we've now got global presence, as we see today, from Australia, from Greece, but also across Latin America, Canada, etc. In response to the pandemic, and in particular, I have to say this, in response to particular requests from our ecosystems, we wanted to develop something that enabled more cross-border collaboration, because our ecosystems like to collaborate. And they like to be able to collaborate together on a number of thematic areas. So with the help, especially with the help of the Scottish Government, we set up what we call our thematic innovation ecosystems. The idea behind these is that they are still the same concept, still led with a patient need, but they're based on collaboration on thematic areas. And we picked to sort of start off with 7 different areas that we could work on, which would enable our ecosystems to come together, pick a topic and collaborate together. All of these ecosystems will be chaired and run by our ecosystems themselves. So this is something that we're doing in partnership with our ecosystem network, where we're helping with the webinars, and we want to build a permanent repository and social media communities, but also we want to go a bit deeper. One of the things with ecosystems is obviously, like many of these gatherings, the ability to be able to have a deeper dive on a topic is vital. Now, today's topic is on integrated care and particularly on communication. If any of you are listening to the news today in the UK, and probably in every other country, communication has been a vital issue. And that issue that's helped either bond or break that relationship between government and the citizen around COVID. None more so than today. So today I'm really excited to be able to launch this first in what will be a series of programs on integrated care. And we'll come back to what we'll go to next later on. But I'm asking for you today to A, listen, and B, get stuck in and get involved. I'm going to put up, after I finish speaking, a link for a small little Google form where you can sign up to any one of these thematic innovation ecosystems to become a stakeholder. It's free to get involved. We want you to get involved because sharing the responsibility helps us drive the direction further. This is part of one of two special sessions on communication that's going to be run in conjunction with Scirocco and with the Scottish Government. So keep informed of this and stay involved. I'm going to stop talking now and hand back over to Andrea for our next part of our conversation. Thank you very much.
Thank you very much, Andy. So we will now move on, as I said, to the concrete experience from two countries. So we'll kick off with Scotland and the presentation from Mamie Thompson. So maybe I'm just uploading your presentation.
While you're getting that up, good morning, everyone. My name's Mamie and I'm presenting here from up in the Highlands in Scotland, and it's pouring with rain, so no change there.
Okay, can you see my slides okay?
Perfect, and if you could give us the next slide, thank you.
Oops, sorry.
Great, thanks. So yeah, this very brief whiz through around some communications around introducing near me video appointments, health and care in Scotland. And although the topic is communications, I really think it's much more around change management, as we'll go on to see. This first slide is that Margaret Worski and Hazel and the team have been slogging away at this since 2016. When there was approval to introduce near me. And this first slide, you can see scenes that we don't normally get: packed rooms, meetings, public meetings. This was up in Caithness in the far north, where there was actually considerable upset around changes in health and social care linked to staffing issues and sustainability. But the one thing everyone did agree on was that people having to have 8-hour round trips for 5-minute appointments wasn't really acceptable. So really, we should have had a big mandate for change, and we did a co-production programs with a lot of support locally, and you would have thought it would have been plain sailing. Next slide, please. Great. So moving on to sort of early 2020, the technology-enabled care team had developed a vision for Near Me. It was published and produced, and this was really just a little bit before COVID. And we realised that if we had a vision to try and embed this technology, we needed to communicate it and try and get some buy-in and support. Next slide, please. And the approach that we took was actually to take John Cotter's leading change, because we recognised it wasn't just about communicating. And he had a very set formula, which is 8 steps of change. And it always starts with creating urgency. And I guess with one of the take-home messages I want you to get is that even though up in the far north and Western Isles and Grampian, there was a clear need to change, that urgency wasn't really created at all, and such to the point that we were only on around 300 appointments per week at that time. So we hadn't created that urgency, even though there was a clear need to change things. So this creating the climate for change, just bear that in mind as we look at the next slide. And the next slide, please. The urgency, so it wasn't patients and the public wanting an appointment. It wasn't the fact that they had to have, as I say, 8-hour round trips for 5-minute appointments. It wasn't the fact that there was a climate change imperative that we were able to change hearts and minds. It was, in fact, COVID-19. That was the thing that created urgency almost overnight. And because of that, it fundamentally changed the way that we had to communicate things. And if we have a look at the next slide, started the role of the rapid scale, and as I say, it fundamentally changed the way we communicated. It wasn't really around trying to persuade people to use it. It was around, this is going to be used and we need to reassure people, we need to get people equipped and ready to use it, and we'll come on to Mark as well. But Professor Paul Gray, who was the Chief Executive of NHS Scotland for 6 years, he was making the point that actually almost overnight, and certainly within weeks, we were able to leap over hurdles that were apparently insurmountable a few weeks ago. And if you see it also on the screen there, right early on in March, the First Minister was out and about as we were trying to promote at every level, political, professional, to get it out, get our message. So again, although there was high profile, again, it was COVID that really moved things on. Next slide, please. As we started using videos, as I said, and you can see the rapid scale up there, it was going, and really in a matter of weeks and months, it went from 300 appointments a month to 15, 16,000. It was an unprecedented level. And given that it was going scaled up so much that we realized that we needed to find out what people actually thought about it. We knew a lot about people who had had appointments and the feedback was incredibly positive, but what about the people who hadn't used it or hadn't chosen to use it? And because of that, we ran a public engagement session. Next slide. It was between the period between March through until June, we did a lot of preparatory work with partners, agencies, health boards, health and social care partnerships to say that we really needed to find out what the benefits and the barriers were from the public and the patients and indeed the professionals. It's fairly high profile. We had to really rely on a lot of organisations. I see Ellie's on the call here. People like Marie Curie, the hospice, all health and care charities, health partners really helped us. We've got a couple of characters here on the screen. We've got there Gregor Smith, who is our Chief Medical Officer, and we have Jason Leach, also Clinical Director, and they helped us with a lot of our media, reaching out, prominent people and all sorts of things, radio, daily briefings, to really try and raise the profile. And part of what we also used is we used Twitter as well to try and really get the messages out. Next slide. I've not put in all the stuff about the public engagement. That's a written up report that anyone can have, and it's actually got our communication engagement and awareness strategy in there, all of the things that we did. And we had a total of 5,400 responses to the public engagement. And that might not seem like a lot, but when we looked into it, that was pretty much more than any Scottish Government consultation had in the past. And I think the second thing was that we didn't do it exclusively online, but we had to do a lot of it online through sort of surveys and emails, also telephone and letter. But we weren't able to have the sort of traditional meetings that we'd had in the past. And when we asked respondents how were they aware of the public engagement and Near Me, then by far and large it was social media and Twitter that people had become quite aware of it. And that was a kind of an integrated strategy. You know, we were using people like tagging in all of the health boards, the cabinet secretaries, the First Minister, to say people like Jason and Gregor Smith, and all of the tech team and all of our contacts, if you like. It was done in what I would say a semi-structured and strategic way. And in terms of scale of that, when we were tweeting early on in January, we were getting something like 78 impressions. And at our peak during the public engagement, we were getting up to 233,000. But it's not really numbers and methods stuff that's important. The important thing was, could we get more people using Near Me video appointments, and were they happy with the service, and did we understand the benefits and the barriers of using it? And that was really the point of the public engagement. I'll just come back to the next slide, please. It's the one before I end. This was just in the news just at the end of last week or beginning of this week, and this is from Aberdeenshire Health and Social Care Partnership, and they had 9 lessons that they had learned that they were presenting to their committee, basically saying that in a crisis we can transform at pace, cutting through normal organisational, financial and administrative barriers. And the best example of that was they said Near Me. As we go on to my final slide, I think it's interesting that the things that they highlighted about being administrative, financial, organisational barriers, my view is I don't think these were the barriers at all, really. To make big system scale change, you have to, whether it's stuff around hospitals, whether it's integration or whether it's the use of technology, you have to align political, public and professional support. And if any of those fall down, it's really difficult to move things at scale. In terms of our strategy, we were very much led that this was something that Margaret and the team wanted to do. So there was high level of leadership, there was a lot of connections, and it wasn't a one-way thing. It was really about trying to reach out to people. And as I say, we connected with 400 organisations who then connected with their organisations. And that's got us to a point really from, as you say, going from 300 appointments a week back in March to now being embedded in the SNP manifesto going forward. And them understanding that it's not just saying that we'll have this, that if people, if it's appropriate to use it, then that is what we'll be trying to do for all many good reasons, and we understand those. But the bit that I think Mark will now pick up on the baton is it's one thing patients and the public wanting to use it. There's also a big change for our professionals, and if they didn't offer it and weren't comfortable with it, then actually that was going to be a challenge as well. And I'll leave it at that. Thank you.
Thank you very much, Mamie. So we will now move on to the presentation from Mark Buick and Gail Nish, and we will continue basically exploring the awareness raising and training remotely during the COVID-19. So Mark, over to you.
Good morning, thank you very much. Just bear with me while I share my screen. I'm delighted to be here, along with my colleagues, Gail and Carol. And let's just pull this up now. And then slideshow right from the start. Okay. How's that looking? No. Okay.
It doesn't have yet the.
Okay, bear with me a minute then. Let's try that again. As I said, always works perfectly in rehearsal.
Whilst we're just waiting on that, one of
Okay.
the nice things about the NHS Near Me, and I put it in the chat function, was that when the Melbourne ecosystem watched a presentation about this right back in May, they were interested in the concept. Margaret Worski presented this with colleagues to the Melbourne ecosystem, where the actual background programme for the NHS Near Me was built and developed. So we had the whole global connector going on. Of us actually saying this has been built and developed in your backyard, and they didn't know about it. Over to you, Mark.
Is that showing now?
No, Mark. Okay.
Oh.
Oh, I think it's coming. Hang on. No, can you try again, please?
Yeah, I will.
Just last time, and then I'll. It was perfect earlier, folks. Sorry about that. Typical.
Yeah.
Before the audience shows up, it's all perfect. Yeah, we can see your slides, Mark. You're not in presenter view yet or slideshow view, but we can see your slides. Yeah, and yeah, perfect.
Okay, sorry about that, folks. Let's try that again. So delighted to be here. I'm really thrilled that we're being able to share this with you today with such a global audience. It's a fantastic opportunity. And we're very excited to be here this morning. So I'm gonna, my name is Mark Bezic. I'm the National Lead for the Near Me Network for the Scottish Government. And I'm joined with my colleagues, Gail and Carol, and I'll introduce them properly a bit later on. So I'm going to just set the scene about our journey from last March until about autumn time this year around Near Me. And I suppose what I wanted to do was really kind of get across how digital was just right through all the work we did in our, as Mamie said, mobilising our workforce to embrace new digital ways of providing services to people in Scotland. And digital was just right through the middle of all of that throughout the whole of our project. And you'll see that as we go through this morning. So as I said, my name is Mark Bezic. I'm joined by Carol Curran, who is a Programme Officer for the Nursing, Midwifery and AHP Directorate for NHS Education for Scotland. And NHS Education for Scotland is a specialist health board within NHS Scotland, and they're primarily tasked with enabling and making sure that the NHS staff in Scotland have the right knowledge and skills to provide the services for the people of Scotland. So Carol is a Programme Officer within the Nursing, Midwifery and AHP Directorate, and my other colleague Gail Nass is a Principal Educator, again within the same directorate. And Carol, Gail and I worked together along with another colleague, Ailey, last year to provide what we're going to speak about in more detail. We very much like to use social media, so we would love to have folk followers, and you can learn about what we're doing and how we're sharing Near Me in Scotland, what NHS Education for Scotland are doing to support nurses, midwives and AHPs across Scotland. So there's some Twitter tags at the bottom there. It's myself at NHS Near Me and also at NES NMAP too. So we would very much like to engage with people on those platforms. Okay, so I previously to my current role, I was working in Shetland, and for those of you who don't know where Shetland is, it's a collection of islands halfway between Scotland and Norway. So we're about 120 odd miles from the coast of Scotland. It's about 12 hours on an overnight ferry and about an hour and a half on the plane. There are 22,000 people living on Shetland. And my job was to provide occupational therapy to children and families within Shetland. So Near Me, as a way of using videos for appointments, we used to connect families with services on the mainland because not everyone had health needs that could be met on Shetland. So people went to Edinburgh, they went to Glasgow, they went to Dundee, but we could do that on video calls to save overnight journeys, to save flights on planes with people with health needs. And also within Shetland, there's remoteness there. We were remote in our location, but also we have people living on little islands. We have islands with 30 people on them. And you're looking at 2 ferries and a day's journey just to get to the hospital where I was. So we used Near Me within our location, not just to connect to the mainland of Scotland as well. So it was an integral tool to deliver services to people in Shetland and to the mainland. So COVID came along, I was using Near Me, everybody wanted to know how to use Near Me. So using digital tools, I then began to use Near Me as a training tool so that clinicians and patients could join us for practice sessions, so they could become familiar and comfortable with delivering their services using Near Me as a digital tool. So I spent a lot of time with clinicians and patients early on in March and April last year, so that services could continue. The next thing we did was we were wanting to try and find a place where we could put good guidance and good information about Near Me. So we had a digital toolkit that was online so that clinicians could then go to that and go, right, I'm a physiotherapist. How do I work out what I need to do from a physio point of view? There's examples of what other people have done on there, and also some basic kind of steps to go through. So we started looking at, how do we get this information out to our wider workforce, initially in Shetland, and then we went kind of national and put this on a practice education community that was a managed knowledge network so that clinicians across the whole of Scotland could then get good, concise information all in one place. So what I'm going to do now is that's kind of set the scene. I'm going to hand over to Carol now, who's going to talk about some of the other digital tools that we used to mobilize our workforce in this new way of working. Thank you very much. Over to you, Carol.
Thank you, Mark. Hello, and thank you so much, everybody, for letting us be part of this conversation. Basically, throughout our whole webinar learning journey, we engaged and used a range of digital platforms and software, including, but not exclusive to, MS Teams for all our planning, organising and debriefs, GoToWebinar, which was the platform of choice that we hosted the webinars from, social media with a focus on Twitter, which we found significant engagement through, WeVideo, where we managed editing of the recordings and we created shared video stories and bite-sized features, Turas, as a repository for our recordings and resources, as well as community of practice sites. MS Outlook, we created a dedicated mailbox, which we managed all our communications from and sent out all webinar attendee resources post-webinar. We used MailChimp to promote and raise awareness of the webinars and encourage registration. And we're now discovering the benefit of animations as an engaging, illustrative information tool, which has added the bonus of letting us create GIFs, which we can hook into through our social media to spread the word far and wide. Mark, are you okay to play the animation?
Yeah, I'm going to just cue that up now. So bear with me, and I can switch to this screen here. So hopefully. Okay, I'm going to just maximize this now.
Thanks for that, Carol and Mark. I'm just going to briefly pick up on how we used Twitter and really how we wrapped a social media campaign around all of our live events. When we first set up our Twitter account, a literature review was undertaken looking at the evidence of the use of Twitter as an educational tool. And obviously NHS Education Scotland, that's our bread and butter. One piece of research we looked at explored how the use of presenter-initiated and generated live educational tweets, or piglets, as you saw in the animation, can help with content sharing and content control during a live session. And we used the findings of the research really to inform how we managed Twitter, really from about 2019 onwards. The research highlighted often key messages from speakers can become diluted as the audience tweet their take on what they're hearing from the presentation or the key messages that the speaker is trying to get over. And this may or may not be in alignment with what the speaker is trying to convey. Piglets also help those unable to attend live sessions still feel connected and to be able to participate, whether that was during the session or continuing the conversation after the session had ended. So a piglet would be a tweet or a series of tweets generated before the live session. So teaser tweets to try and improve engagement and just really inform people that the sessions were about to happen. Mainly during the session, so live tweeting during the session was something that we paid particular attention to, and as I've said, continuing the conversation after the session ended. So the webinar team would schedule the tweets in the run-up to the event using TweetDeck, but would always have someone available during the session to tweet in the moment. So for the webinar series, what we did was we liaised with our speakers at the planning stage and really asked them to provide any content that they wanted us to share. So their key messages, any graphics or images that they wanted us to use, the key hashtags, and more importantly, any influencers that we should include in the tweets, really to get that dissemination as wide as we possibly could. So we have got a process that we use to gather this information, and we develop a tweet plan from this. And we also make sure that we link in with our organisational corporate account, again, just to help extend our reach. And although it wasn't the intention, what we've noticed is our net followers and tweet impressions have increased hugely webinar on webinar. And so we continue to advocate the use of piglets. Thank you.
Thank you very much, Gail and Mark and Carol. So we will now move to our last presentation, where we will be kind of like looking at examples of communication strategies and healthcare literacy initiatives in Lithuania. So Rokazel, pull up your presentations.
Sure. Thank you. Good afternoon, everyone. We have a few minutes to go through well, health literacy, how we see it in general, and how we see it in COVID-19 perspective. Next slide, please. Well, non-communicable diseases account for the vast bulk of money spent by health and social systems. But they are, to a large extent, preventable. Non-communicable diseases are prevalent and basically increase with age. We know that. World Economic Forum reported that by now, people who are under age of 5 should be outnumbered by people aged 60 and over, which means that, well, the chronic conditions are due to rise. Many of non-communicable diseases share the same behavioral risk factors, such as smoking, alcohol consumption, unhealthy diets, and physical inactivity. Therefore, I would just repeat myself that they are largely preventable. However, behavioral risk factors are mainly in the hands of patients rather than the healthcare systems. The data I'm sharing now basically just proves that the chronic conditions are rising with age, and this, in fact, correlates in all the world. Next slide, please. We know that people over their lifetime develop diseases. However, we also know that people over their lifetime learn to live with a chronic health condition. Let me take diabetes as an example, where patients engage in their self-care. They achieve great results, and they actually achieve great results in health resource usage, as well as outcomes and even life quality. It proves the necessity of patient empowerment or health literacy in our case, which is the reason for our probably discussion today. We know from the data being available that one disease is manageable by the patient. Let me take the same diabetes example. But aging population and the increase in long-term conditions mean that the number of people with multiple health conditions is also set to rise. This multimorbidity, or coexistence of two or more chronic conditions in the same patient, has a specific impact on primary care and extremely poorly coordinated by the patients themselves. Multimorbidity starts to increase at the age of 28 years, and it grows more rapidly in younger patients than in the elderly. Therefore, when do we need to act? We need to take a careful consideration, which basically says the earlier, the better, especially when we're talking about patient empowerment. The monetary costs associated with managing multiple chronic conditions are overwhelming and growing with age, and are higher compared to patients with one chronic disease, because of the same reason that patients with a single disease, they tend to get involved into their own care. So the rising burden of chronic diseases and multimorbidity requires countries to confront the fragmentation of health services and shift towards integration, linking or coordinating providers along the continuum of care and putting the patient basically at the center. Primary care is the key actor here, but numerous integrated care models of different shapes and sizes are found around the EU, which hopefully answers the question, why do we need the increased healthcare literacy and patient involvement? Next slide, please. There is knowledge that's previously available to all of us, which set the ground for initiatives or reforms in the healthcare across the developed world. But COVID has shifted the urgency of that change, often highlighting the old known changes or challenges and showing their impact or real dysfunction of theirs. Patient empowerment based on health literacy became the key factor in how the healthcare setting functioned when all non-urgent work was put on hold during the COVID year. So previously worked on health system reforms focusing on general practitioner development for outpatient healthcare services, especially to implement innovative multimorbidity health services models on a national level, much of which is aiming to have the patient as an active team member involved in their own treatment. And that was the key priority in Lithuania before the COVID, and was much more emphasized during the COVID year. Three main things: healthcare and social intersectoral collaboration, a functional integration of primary healthcare and public health, and the last but not least, teamwork in family medicine, which has been introduced and expanded. The team of family physicians was supplemented by additional team members consisting of GP, nurse, midwife, nurse assistant, lifestyle medicine specialist, physiotherapist, and social worker. Last one, but an important one, because virtual or distant support and teamwork was facilitated during the COVID year. Huge change here with ITO services, and obviously a mind shift about the distant work for teams, which seemed to be possible. Next slide, please. Over the past years, Lithuania has been prioritizing big spender group, much of which was non-communicable diseases. In other words, how can we take control of resources being used for a purpose which is not being served? Let me expand on that. Non-communicable disease patients, especially those with multiple chronic conditions, they prove to be using vast amount of healthcare resources without considerable gains in their life expectancy, nor in their life quality, nor in satisfaction about the care they are getting. To address that initiative, working on good practice identification, sharing, and implementing were looked at, and projects like Scirocco and others played key role in identifying the good practices which could be piloted and scaled up in the country, much of it which was about integrated care. Integrated care has many pillars. One of the important ones is patient involvement. Now, what is or how do we get patient involved? Well, 4 simple things. The first one is to educate the patient about their disease. And it is especially important when we're talking about chronic conditions, as this is something what they get for the rest of their lives. The second pillar is to empower them to take the control. So measure or make an impact on what they measure. And as an example, again, I will be coming back to diabetes as a single chronic condition. We educate the patient about the disease. We empower them to take control. So measure their glucose and understand how to affect it. The third pillar is agree on the measurement aim. So agree, the medical team and the patient agree on what is the glucose level, which should be aimed for. And the fourth one is providing regular support for the patient when needed, which means the patient has to have access to medical team when he is not in control anymore. Simple 4 steps allowing to empower patients 24/7, look after him or herself, which proves to be a huge support for the medical team. They proved key during the COVID period, showing very different outcomes in those involved and empowered, and the rest, counting on the healthcare system. Much of it actually was put on hold, as well as the support they were counting on. Next slide. Thank you. As mentioned before, identifying good practices and working on them on a national level is proving to be a shortcut to low-hanging fruits. In this case, putting enough emphasis on the third one, which is provide tools to strengthen patient self-management and self-efficacy. Next slide. After the patient is educated and key results we are aiming at agreed on, they need an instrument to help them measure the process. As an example, I'm sharing a tool, or in this case, a platform, which became available, and not only available, but also used and prioritized by medical personnel and accepted by the patients in the light of COVID-19. Let me shed some more light on it. The developed and implemented telemetry technology is basically implemented in 4 stages. Measurement of patient health indicators with medical devices at the patient's location. So as agreed, we empower the patient to measure himself. Then transmission of the performed measurement data via either Bluetooth or any other form, in this case, Bluetooth connection. Processing the data in a microcomputer and their transmission via local network cable to a router and further to an internet connection, basically to a cloud. And the fourth one is transmission of patient health indicators stored in the database for the medical staff and the patient to be available. Next slide, please. Having the patient measuring their status and the system then uploading it to the cloud, it allows the system to be invincible between the patient measuring and then analysis happening 24/7 in the cloud, highlighting the struggling patient for the medical support team when they are actually needed. And that allows the team to proactively support the patient just before he starts deteriorating and reaching out for urgent medical services because the non-urgents were not available. Next slide, please. This is an example how the measured data transfers to a monitoring tool, supporting both the patient and the medical team. Blood pressure is just one example. Another example would be weighing scales for heart failure patient. When his dry weight is agreed on and aimed for, having a clear cutoff when the medical team should be engaging or the reviewing his or her diuretics distantly, and injecting that information into the system so that when the measurement exceeds the agreed number, the medical team is being notified. And that often prevents them deteriorating further and avoiding urgent hospitalizations for deteriorated heart failure patients. Next slide, please. So as noted before, for the patient to be empowered, few things need to happen. The first one is education, where health bureaus in Lithuania have taken a key role to support the medical teams and make sure that they're not overloaded. Also, financial and legal background for making the online consultation or support possible. Next, the support, let it be for the patient or another medical team member, which is based on agreed planned schedule and form for that agreement to happen. Here, ITO tools development and a mindset shift during the COVID period helped really a lot. And last but not least, empowering other medical personnel to take more responsibility through agreed responsibilities and clear support or reporting standards was also playing a key role. Next slide, please. So COVID-19 proved that health literacy was one of the key factors, either supporting the health systems to function when on hold, and therefore became a priority for a large part of the world during or after COVID-19, which is being seen as a great opportunity for future change in healthcare delivery, much of which is actually built on the same pillars as the integrated care models. Thank you.
Thank you very much, Rokas. It's Nessa here. Just while Andrea is changing screens, I'm going to kick off with a couple of questions we have from the chat, if that's okay. So I had actually a question myself, but I think it's a bit cheeky to ask my question, so I'll wait and see if there are others that are coming through. So I know, Andy, you had a couple of questions about the use of Near Me and for Rokas in Lithuania, about how can we raise expectations and then demand around communication from patients. Have I phrased that correctly, Andy?
Yeah, I think the reason I raise that is we're using technology that we know in methodologies that we feel safe with, and gradually we're raising the usage and demands from patients and carers and citizens. My question is how do we raise the expectation to say, well, actually, we what's next? What's the next new thing that we can use to really, help? And in the same way we would with, physical tools, we use different ones now than we did 10, 20 years ago when I started in social care. How can we think, well, how can we use some of the, emerging technology, digital technology to even more enhance that communication?
Rokas, if we go to you first, would you like to comment?
Sure, Andy, thank you very much for a good question. Well, I would feel that, well, this actual situation where all of us are in actually is a great support. Things like having online people, well, students, pupils, are like second graders sitting and having their teaching session online was something unimaginable, right? And exactly the same with the patient. Only really early adopters would consider having a teleconsultation with a doctor. Now, over that last year, what happened is much of what is we feel safe with was put on hold. So basically, it became not available anymore. So basically, we had a vacuum, an emptiness, and no support. So that was a really good time when basically we could say, look, we don't have that safe option anymore. So what else do we have? And that's exactly where the ITO solutions came in and said, look, we can't meet, but we have other options. So from basically having only early adopters looking into it, we have a whole lot of people actually saying, look, I know my child is using it, so it should be safe. I know my grandma or my friends are using it, it should be safe. So I would say, taking this into consideration, we should not necessarily now concentrate on what is the next big thing. We should probably concentrate more on what are the big things, what were being used over the previous year, and how can we make it as a mainstream? Okay. Because we have a really good period for it to happen.
Thank you, Rokas. I'm just going to jump ahead slightly because I know we're up against time. But the last point also, Rokas, links to another question or observation from Andy. Question really, how could we reuse the tools that we already have to, for example, create new communities of support? I assume there, Andy, you're thinking about for patients, for carers, for citizens.
For carers, I mean, I'll just pick on the carer side just for now, because it's slightly different. But you know, we've done this in the fields of dementia and in mental health with schizophrenia support groups for carers. But how, you know, we're thinking, obviously this is very much practitioner to patient or whatever term we might have, but we can also think we can use those networks of support we've built up physically for carers, but use these tools to bring in information, education, and communication to help carers to reduce burden, share best practice, share good learning, because that's what, in my experience as a practitioner, that's what was the demand.
Thank you. I'm going to come to Gail and Mark and Carol next, actually, on a related point. I think it's very important, obviously, to talk about carers and patients and the use of technology in this way, but I think it's almost as important that the staff are on board and that the staff are carrying that message and supportive of the use of technology. So I just wanted to ask, I'll go to Gail first, actually. In your experience, I mean, predominantly you've been using this technology to deliver training and education and had a massive success. I mean, really unexpected and unprecedented success in this past year. But have the staff, broadly speaking, come positively to it? And can they see potential then for use with their own clients, patients, etc.?
Thanks, Nessa. Excuse me. Yeah, absolutely. We have, I think for us, certainly the visibility of NHS education as an education body and what we can offer to our workforce was one of the kind of unintended benefits of the webinars. What staff have been feeding back to us is they're looking for education on how to use the digital platforms, so GoTo and Teams, to deliver education. And that's certainly something that we, as a subsequence of doing the webinars, have really focused on. So really thinking about developing educational content that works. So the whole technology enhanced learning agenda. So yeah, how they develop content that they can use to educate their, whatever client group they're working with, whether that's carers, whether that's patients, whether that's students or their peers. As I've said, being confident in the use of the platform is absolutely key in terms of the quality of the learning environment, and also skills around facilitating and engaging in an online space is really important. So as a result of us, carrying out a lot of the work and learning for ourselves, it's a steep learning curve for us around moving very quickly to deliver technology enhanced learning. Our focus now is around how we build knowledge, skills and confidence with the workforce.
Thank you very much, Gail. I don't know, Mark, if you want to come in. It does strike me personally as always slightly surprising, given our own professional struggles at times in the past 14 months, and even before that with using technology to communicate. Somehow we seem to expect patients and citizens to just get it immediately. We can be a bit presumptuous on that one. So Mark or Carl, if you wanted to come in there, I don't know.
I'm happy to jump in and just say, I think in terms of getting alongside the workforce and working alongside them, and we've done a lot of rapid quality improvement projects with different sectors of clinicians across Scotland. And that's when we run things like tests of change in small steps, and groups of clinicians go, oh, I can see how this works now. And then we've been able to scale that up and produce guidance, so that's then scalable across Scotland. And also the magic thing about the webinars is we pulled in people from those professional groups to share their story. And we can quite happily bang on about how great Near Me is all day, but if you're a clinician and another clinician who does the same job as you says, I'm using it for this was a challenge, this was great, we've overcome that by using this, that person then goes away from that webinar thinking, I think I can do that where I work. And that's been one of the biggest powerful tools we've used, is to get alongside and use skilled clinicians to spread the word to similarly qualified clinicians.
Thank you, Mark. Just as we're coming up to the end, I have one really quick final question, and it's too quick really. And that question was posed by Donna Henderson, and she was asking whether any of the other regions have been using social media in particular to communicate with the citizens, with the patients. I don't know if any of our international colleagues would like to jump in. Rokas, I'll go to you first about just on the use of social media as a communication tool.
Well, no, from our end, we were stuck with what's safe. So we said, look, it's enough for the system to be on hold. It's enough for a change. So let's stick to the usual convention phone line, and shifting patients to online communication. That is a big change enough. So we were not using much of the social media here.
Thank you. And so that's the next avenue, perhaps. I know Donna's making a broader point about engagement more widely in digital health and care, but with citizens and professionals. So I'm just going to hand back to Andrea or Andy, who's coming in just to wrap up.
Yeah, it will be Andy for our next step, more general for the ecosystem. So Andy, I'll leave it to you. Thank you, Nessa.
Thank you. Thank you for that. And thank you also for the great practices we've heard from today from Lithuania and Scotland. Both are where we've got some fantastic ecosystems already. And if you're not involved with them already, let me know. We can plug you into the great ecosystems we've got there. In terms of next steps, we've been hearing today some nice questions about how we involve and include and use social media. We've heard questions about how we work with and target carers as well as patients. So in terms of topics, what we're trying to do with these thematic innovation ecosystems is use the same model we do elsewhere with our ecosystems, and start with a particular topic, a subtopic, and it might be social media and its use in integrated care, or it might be how we involve and include carers, etc. And what I would like to be able to do is, with colleagues from Scotland, is include some of our members, our other ecosystems, to start back with the idea of what's the need. So what's the need around social media? Where's the best practice? What are some of the issues? What are the policy implications? And then use the examples we've got today to help drive that discussion. So I put in the chat function below you a little Google form. All it is to collect some information in terms of where you want to get involved with one or many of our new thematic ecosystems. But also, I will be then contacting people to say, well, what do you think? Because we've already had some input from European patient groups, European carers associations, as well as other ecosystems, and what they think and would see as good practice on integrated care. So those are the things we'd like to be able to concentrate on in the future. With that, I'm going to stop talking again because I'm conscious we're just overrunning, and thank all of you and all the presenters for your contributions today. This has been recorded and we'll be sharing this on Catch-Up TV, as we call it, and via social media. And hopefully then listening to more of your input in terms of stakeholders. Thank you very much. I'd also like to thank the Project Scirocco Project too for taking part too. It's very, very valuable.
Thank you very much, Andy, and thank you everyone for participation, and particularly to our speakers, and looking forward to seeing you at other sessions this week. Have a great day. Bye-bye.
Goodbye.